Sorry, what's Okay, Basola, this is what you need. The invite link I need. So you can copy this link now. Send
Invite link. There's nobody there. If that is off, then I can go and use that. Yeah. What's with this one? That's mine.
What's your own? Where's your online already? Add people.
Yes, I need that.
It's coming from. There's no plug. There's no plug.
They can't see me yet.
Yeah, because you're not on a video.
Austin. Austin. Hello, Austin.
Hey, Obi, how far now?
Oh, no. I did.
I do. Don't catch me again. Here. When I hear you there, I say, okay, I will just spend the time listening to you now because once you are here, you cover everything now. What do you want to hear again?
See who's talking.
What shall we talk with you? We don't be nice here.
See who's talking. Eh?
We just listen to you now.
Don't let me expose you anyway, but you'll expose yourself.
What you want to expose?
When you start now, you'll expose yourself.
Yeah.
So, well.
Good afternoon, everyone.
Good afternoon.
Good afternoon.
Good afternoon.
Good afternoon, Dr. Austin.
Yeah, good afternoon. Dr. Shala, how are you doing?
Good afternoon, Mr. Abajue.
Yeah.
Good afternoon.
How are you?
Fine, thank you. Olamide.
Dr. Olamide. Good afternoon.
Please, can you correct his name to Dr. Okulaja?
Dr. Okulaja.
I see it written there as Mr. Okulaja. Who is deceiving who?
He's the one trying to hide himself. Dr. Dada, good afternoon, sir.
I'm good.
How are you?
I need to work.
Dr. Austin, how you doing?
I'm all right here.
So when are we
beside you?
Thank you. Yes,
Good.
I'm just doing the final setup so that we can start. Just give me like 5
minutes.
minutes.
Okay.
Yeah. Well, for right. The guys that refuse to give me money.
We refuse to give you money.
Yes, no.
Guys, take that offline. Though. Take it offline. Take it offline.
No, we're not on yet, so we can afford to say the truth. Now we'll get there. We can know how to discuss the matter.
You don't need money now, Dr. Austin. Wait, what do you need money for?
I mean, please let him know that I need money, I beg. I need money. Let's say we did Nigeria Delta. I heard they flew from here, go Abuja, then they come back. So please, let's
they come back.
Once the crude oil flows with the dollars, doesn't come back here. One way. How are they now? That's Lagos.
Lagos is fine, though. Lagos is fine with the push up.
Happy independence. Finally 60. We don't know what now. Don't they turn elder now? Senior states country, what do you call it? 60 not the easy age. Still trying to find our feet, eh?
They said we are live, so everybody just calm down.
Hey, I can stop already.
They should have told us we were live now.
No, they couldn't have done that now. We just keep serious face now.
I just got a call now that we are live.
No more here laughing. I beg. We'll talk straight. Anyway. You won't believe it. Huh?
Right. Let's sort out this.
Let's start recording.
Yes, this start recording. He said we should record to cloud. Yes.
So I think someone is already recording it. This one's already recording it. That's it. You connected or someone's already recording. No, yeah, it's using my hotspot.
Someone is already recording.
It's using my hotspot. Yeah, but no, I can hear him. It's using my hotspot. I can't go. If I know, I can go.
Who is recording, please?
I don't know, because see, maybe one of your because if I do record, I will come.
So, do you have an idea? Who is recording now? Does it record automatically?
No, because
No, you have
you
to.
want to stop that recording. That means someone is already doing
Yeah,
it.
yeah. They've automated it.
They've automated
Yeah,
it?
yeah.
Okay.
Yeah,
So, which is like
So I don't have any problem now.
yeah, right now. But okay, it's talking about internet. Let's just. That's what you can see.
That's mine.
The switch is so far from here.
That's Swift. Don't know if Swift.
It's too. It's down.
Yeah.
It says that.
Sorry.
No. It's in PNG.
Yeah, yes, Yeah, yeah.
Can you hear me?
Yes, we
Yes,
can.
yes, we can hear you now.
Yes, we
Oh,
can
okay.
hear you.
So sorry about that.
Hey,
All right. So once again, I said I'm so sorry. We apologize for starting a bit behind schedule. I want to wish everyone, especially our panelists, a happy Independence Day, and we are so grateful for sparing this few minutes of yours to come and then deliberate with Nigerians, and of course, especially those who are in the Nigerian healthcare space concerning the burning issue that is before us, that we have termed sustainability and profitability in the Nigerian health sector. It's the elephant in the room that we need to tackle. Now, to listeners at home, I have before me 4 distinguished panelists who are experts in their own field, and then I would take the first few moments to read their profile, to introduce them in no particular order. Firstly, I'll start with Dr. Austin Okogun. Dr. Austin is an occupational physician by training. He is the CEO of Lily Hospital Group, branches in Warri and Benin. Lily Hospital is the first hospital in Nigeria to be certified by the NIS to the ISO 9001 QMS, and one of the few accredited hospitals by international accrediting body.
Okay, so I think that a lot of people have been waiting for us to speak, and people can actually really see us. And
Okay.
I'm personally getting
It's back.
messages.
It's back.
Is it back?
No, the link is, it will drop momentarily, but he's not back. He's not back.
Okay, so I mean,
we're
maybe
hearing
we can,
ourselves. Am I getting him?
yeah, maybe we can just start some conversations while we wait for people for the link to come back up.
Do we want to just, since they sent us the program?
Yeah, so I think that maybe until they sort themselves out and people start talking, maybe we should just introduce ourselves instead of him introducing us, and then we can then wait for them to come back. So I'd like to call on my Egbon. Dr. Adedamola Dada to please introduce himself if he's on. Good. So Dr. Dada, please can you just go ahead and introduce yourself?
Yes, thank you very much. My name is Adedamola Dada. I'm the Medical Director of Federal Medical Center in Lagos. Thank you very much.
Thank you very much. And then my brother, Mr. Abajue.
My name is Obainnia Abajue. I'm the CEO of Hygia HMO Limited.
Okay.
Okay, and then Dr. Okogun.
Well, I'm sure they had a bit of my own introduction. Dr. Okogun is my name. I'm the CEO of Lily Hospitals here in Warri, and we also have a branch in Benin. Thank you.
Okay, and I'm Dr. Olamide Okulaja, the Director of Advocacy and Program Development at the Farm Access Foundation. And I think that the link is back and our host is back, so I'll hand back over to him. And we should just move straight into the conversation.
Yes, Dr. Okulaja, thank you so much for standing in for me. I'm so sorry for that. So we'll go straight to the question. I want to start with Dr. Okogun.
Yes,
Yeah,
I can hear you.
All right, I want to start with Dr. Okogun. India has been the go-to country when it comes to affordable medical interventions. It has been noted that most facilities that carry out the medical procedures are privately owned and run in India. In Nigeria, we have a lot of private hospitals, but apparently they lack the capacity to provide such level of care consistently. Why have we not been able to attract medical attention like India in terms of medical intervention, seeing that the wealth that healthcare business has attracted to India currently stands at roughly, it is projected to go to 320 billion US dollars by 2022. So over to you, sir.
Thank you very much. The reality is that what the Indians have done is not anything that we all are not aware of. From a service standpoint, you know that if you look at the capacity of Nigerians all over the world, wherever they are practicing medicine to deliver service, is huge. I mean, we have over 3,000 Nigerian doctors in the UK and over 10,000 in North America, practicing medicine at various specialty levels, even advanced specialties. But I think where we have failed, our inability to attract them back. That's what the Indians did. They were able to bring back these highly qualified Indians to go back and work in India. So the enabling environment, was created, supported by government, that attracted a lot of them back home. And of course, with those level of personnel coming back home, they also attract the kind of funding, that may support, the healthcare infrastructure to enable them practice. While we have comparable quality of doctors, outside of this country, I do not think both on the side of the businesses, the healthcare business in Nigeria, and also government in itself, that we have thought it through how to attract them back home, to practice. There's a combination of several factors. The issues of security, and even the currency, the buying power of the locals, our health coverage, in terms of insurance health coverage, the payment systems. There's a whole lot that needs to be put in place in order to turn the situation around for the better. So I think that is one of the areas where that has happened. Then secondly, India competes also very favorably in terms of pricing of the healthcare services. A lot goes into pricing. Material costs, equipment costs, and all the input costs are all that lead to the kind of pricing. So even if you bring these Nigerians back home and they come and practice their trade and do it very well, they may not be able to compete in terms of pricing. And that they still not make Nigeria a tourism destination. Unlike India, where there's a lot of manufacturing going on, here we're not doing manufacturing, instead we're importing a lot of items. And we import almost everything, to consumables. Even syringes and gauze and all are imported. So how can you compete with a country that manufactures? Many years ago, when we were trying to set up an IVF center in Lily Hospital here, 2007, we were desirous of offering services that will be affordable. Knowing that a lot of Nigerians were infertile, many of these people that were infertile were not rich or poor, and one of the reasons people could not afford to do IVF at that time was because of the pricing. And we knew that in India, things were quite cheaper than it was in Nigeria. We took a trip, me and my partners, to India. We spent about a month trying to study their own system to know why they could offer their service at such a low price. One of the things we discovered was that they manufactured a lot of their consumables. And that way, they could drive prices down. And we couldn't do that same thing in Nigeria. So we will continue to be at a disadvantaged position unless we take deliberate steps, to turn this around, make, our country healthcare system attractable to Nigerians that are abroad, and then also match that up with, some efforts at manufacturing or any kind of support from government that brings the price input costs down, even if for a period of time, like a subsidy that will drive down the price of our services, and they can jack up the quality with kind of personnel that can travel back home and they can compete favorably. That's my take. Thank you.
All right, thank you so much. So I want Obainnia's input on that, please.
Okay, thanks, Shola, and thank you, Dr. Okogun. I think that the issue about the input of personnel and the overall competitiveness of India as a community, as a country as a whole is very important and can't be overlooked. And if we think about things from the perspective of a market, then we realize that what India did was to create a market. They used the advantage of the base that they had to create a market in which they could actually control, is a very loose word, but I mean, it kind of helps to understand that India ensures that there's production going on in terms of the inputs to supply. And because they already have the people, so they can achieve a scale that allows them to be able to compete favorably. India in particular also encourages a lot of innovation because they have a market. So those people that are coming back from overseas and the people that are growing within the Indian society are able to set up businesses that thrive. And those businesses are able to make significant amounts of money within that environment because they ensure that the items of production, like generic medication, cost of equipment and all that, because it's done locally, the cost of those things can allow them to be competitive. In our environment, to what Dr. Okogun said, we have to think constructively about how we're going to ensure that the inputs for our services or it can be achieved at a competitive level. We've got companies that are able to do manufacturing. How do we encourage them? We have people who are willing and who have the talent for people. How do we support them? But that's kind of how we need to think about it to progressively grow a competitive market that allows healthcare services to be provided in Nigeria. Thank you.
All right, thank you so much. So Mr. Abajue, I will go to you next so that we don't waste much of our time since we have had to stay for some time. So there is a school of thought that views the healthcare sector or the healthcare business as a social safety net. For the average Nigerian, the major health crisis, any major health crisis they encounter further pushes them into poverty. So the question people are asking is, what are the wins and the low-hanging fruits that can be harnessed by policymakers, by health insurance companies, and the populace at large to increase our goal of achieving the universal health coverage?
Okay, thank you very much for that, Shola. I think that, yes, first we have to accept that healthcare is a social safety net. All right, it's something that is vital for any society to survive over the long term. All right, it's only people who are alive that can contribute to a society. Now, but when we think about issues of sustainability and the impact of healthcare on productivity, then we kind of see that the supply and demand for healthcare services is probably most safely conducted as an economic venture, if you want to see that the thing is sustainable over time. And that means that the significant amount of capital that is required continuously as an investment in healthcare can therefore be adequately aggregated, because money flows to where it is welcome, all right? So you have to be able to aggregate it safely and then appropriately manage it. And really, the world has determined over the last couple of centuries that the most sustainable approach to managing resources is really as an economic venture. That's the most sustainable approach. Everything else struggles, and that's been proven over time. So when we think about that, what are the lowest hanging fruits that can be harnessed towards UHC, universal healthcare? I think for me, one is the scale of participation we can achieve in Nigeria. We really must focus on trying to get everybody on board, all right, under a health scheme, whether private or public. And then we should avoid the overlaps and double counting. So you can't have people, everybody pursuing one set of people and another set of people are completely uncovered. And literally, you have to have this thing where the government is focused. If the public is going to play, then they have to play in the hardest parts, so the private can play in the easier parts, all right, because you cannot use what you have and let people play to their strengths. The second thing is the awareness of the need to take out health insurance. You know, most things are cultural, and cultural is often tied to education. How do you educate people? What do you teach them? So our policymakers need to consciously think about how to champion awareness of healthcare. If people are brought up thinking that stuff is free, when they are older, that is the mindset that they've been brought up on. And therefore, all their actions are built on that platform of expectation that this is free. If, however, they are taught early that there's a reward and a compensation for what is put in, and this thing is not free, somebody is paying, then there's a mindset that grows up on the fact that value must be exchanged, all right, and people must be paid and rewarded for the service. Now, if we teach people like that and then drive their awareness, it makes a huge change. If you go to Europe, one of the reasons why in those environments, dentistry in particular is very profitable, is because they teach them from the beginning about why it is and why it should be, and brushing your teeth and all of those things. So everybody grows up believing that they must go and do this, and that helps to create a market. We need to drive that level of awareness at a policy level with health insurance to get the kind of result that we want. The third thing is technology, all right? The adoption of technology can save a lot of cost, allowing us to leapfrog a lot of things. So what we do in harnessing technology to be able to provide access to care is vital to ensure that we can actually achieve what it is that we want. And it's a low-hanging fruit. It's available. We have the people, we have the network, we have the capacity. So trying to use that to improve transparency, quality of service by defining the standards of basic care very clearly. That is really what is basic care, what is accessible, what is covered, what does it mean? If we add regulation to that, we can define what is primary care, what does it cover, what doesn't it cover? How do you use branded drugs? How do you use generic drugs? All those things that make for transparency, ease of understanding. Technology can help us to drive access to care for everybody.
Just help me to summarize now.
Yeah. So the last thing I will say to you is that the balance between social service and profit making will come when there's clear separation of duty. Who is doing what? What is the government's true role? What is the private sector's true role? And that will help us to get to where we want. Thank you.
All right. Thank you so much. So, Dr. Dada, I want your take on that question.
Well, thank you very much. Without repeating some of the things that you have said, I think one of the biggest challenges too has to do with the fragmented nature of our healthcare system. You know, because it's fragmented, efficiency is almost absent. And where there is no efficiency, then cost will certainly go up. And so I think one of the low-hanging fruits is for us to try to get a structured health system that is efficient and that is functional. And I will give you an example. If you look at the primary healthcare system is quite weak. And you can imagine the consequences of it is that we then spend a lot more money taking care of our people, all right, which ordinarily would have been a lot lower if the primary care system was working. All right. Now, let me give you another example. You take a look at cerebral malaria, for instance. Okay, if our primary health care system is functioning well, okay, then you would have very, very few number of cerebral malaria. Okay, if we're able to pick the malaria, the child that has malaria at the first or second day, okay, you probably would spend less than 1,000 naira to treat that patient. All right, but if because our primary health care system is not functioning, okay, that child now needs to go to a tertiary institution with cerebral malaria. To treat a child with cerebral malaria, you probably will spend about 300,000. Okay, this is the same disease you could have prevented and treated with 1,000 naira. All right. So we actually need to work on the structure, on restructuring that system so that we can actually make it a lot more efficient. And then, of course, the health insurance scheme. There is nowhere else in the world where you don't have a strong health. But as a matter of fact, health insurance scheme, okay, a good, efficient health insurance scheme, okay, goes with a strong health care scheme. All right, because if you don't have a strong health insurance scheme, then at the end of the day, patients are exposed to catastrophic consequences of sickness. What basically insurance does is to ensure that those that are well, okay, are able to pay for those that are sick at the point of need. But unfortunately, I think only about 5% of our population is covered in the health insurance. So for me, these are some of the issues we need to take a look at. Okay, ensure that our fragmented system is well structured so that at the cost of healthcare is substantially reduced. People talk of India and medical tourism, and people have quoted a lot of figures: $12 million, or $12 billion. Some have said $5 billion. Okay, the truth is that we actually don't have that figure, but it's a lot of number. All right. Now, why do people go to India? Basically for three main reasons: for the cancers, for renal diseases, and for heart diseases. But a lot of these conditions can be prevented so that you don't even get to the stage where you need to spend billions of dollars to take care of these people. For instance, at the level of hypertension and diabetes, if you have a good health insurance, a good primary health care system, okay, where that can actually attend to people at the preventive level and prevent some of these things, then people don't suffer catastrophic consequences of hypertension and catastrophic consequences of diabetes, like failure of the liver, cardiac failure, and all the rest of them. So you can imagine the consequences on the cost if you're able to prevent some of these things, and then you don't get to the level of complication. So in summary, I think we need to take a second look at our fragmented healthcare system, get it structured, get it firing efficiently so that it can save costs and also serve the Nigerian people.
All right, thank you so much. Thank you so much. Dr. Okulaja, I'll go to you now. Can you hear me?
Yes, I can hear you.
All right, great. So there are a huge array of gaps in the healthcare system value chain. So not just healthcare provision, but the whole healthcare system value chain that remains untapped. Most of the time when we look at our system in Nigeria, there's a huge focus on healthcare delivery alone. We have focused on the curative aspect majorly. So the question is, what are your thoughts concerning harnessing other areas of the value chain that remain untapped? And of course, we want also to, tap and pick your insight on what other virgin areas people can capitalize on.
Okay, thank you very much. Thank you very much for that question. First of all, I'd like to acknowledge all my other panelists. Everybody here is a very close friend and very close brother to me. When you talk about the healthcare value chain, healthcare basically is divided into two. It's divided into demand and it's divided into supply. So you have demand and supply. Demand is the ability for people to be able to access healthcare through some level of purchasing power, and supply is the ability for people to be able to deliver that healthcare service. Now, I've heard a lot of people speak, and one of the things I think we must always remember is that healthcare in itself, or the provision of healthcare, is a huge market failure. Why? Because a lot of times it is regarded as a public good. So when you talk about it as being a public good, basically, like you said, a lot of people think that it's a social service. And then when it's a social service, it is fraught with a lot of inefficiencies, as a lot of other people have mentioned. And so one of the things that I think personally is that we need to move away from that and begin to look at healthcare as some level of business. And when you say business, I don't mean in terms of just buying and selling. I mean in terms of it being efficient, in terms of people being able to creating a situation where people can, afford healthcare without going into financial catastrophe, and a situation where people can also deliver the healthcare service that is required. And so when you talk about in terms of demand side, you see, it's important that every economy and every country determines the type of healthcare financing mechanism that is required to cater to its people. A lot of times we do a lot of copycat interventions where we just take some intervention from another country and try to place it on ours. In the UK, it's a tax-based system. In Germany, it's a social health insurance. In America, it's totally capitalist, run by HMOs and all of that. But, so again, one needs to look at your environment and the demography and see how, that can really, gain some form of traction. The reason why I'm saying this is because if you do not have a viable demand side where people can actually really access healthcare service through some level of purchasing power, then the supply side will forever fail. It will forever be starved of the needed funds to maintain the level of quality that is required for it to deliver, effective healthcare, which we have seen in Nigeria. And one of the major reasons why you see, the healthcare industry this way is because, look at the demography. You have about 80% of the population living below the poverty line. You have over 70% of people paying out of pocket. You have over 40% of the poor accessing care from the private sector, the poorest of the poor, and I'm not just saying that. And this has led to a lot of constraints to health-seeking behavior, right? And because it has led to constraints to health-seeking behavior, people are not accessing care from these facilities, and then these facilities are starved. So you then have a disintegrated and a healthcare system filled with ambiguity, where you begin to see tertiary facilities providing primary healthcare services. And you begin to see primary healthcare services providing secondary healthcare services. And everybody it's now the battle of the fittest in how to stay alive in whatever we've done. And this is because we do not have some level of organized demand side intervention. I'll give you some very basic statistics. In 2017, I don't have any earlier data. The total healthcare expenditure in Nigeria was $44.1 billion. And out of this $44.1 billion, you had 77.2% of that coming out of pocket, which meant Nigerians dipped their hands in their pockets to pay for healthcare. However, we still have, the worst health indices in the world in terms of our maternal mortality burden and neonatal mortality burden and all of that. If we are able to direct that into some level of pre-pooling mechanism that can then be used to pay for services for a group of people, then we may begin to see a supply side that begins to receive some level of funding that it requires to maintain its quality healthcare. Now, if money begins to go into that system, one of the things you begin to see again is you begin to see a sequence in which healthcare service is delivered, because then people will start focusing on areas of specialization between primary, secondary to tertiary. A lot of times people really focus on governments being able to provide the funding required for people to access healthcare. Healthcare must be free. But if you look at our society where you have a tax to revenue ratio of about 6%, even at the level of Lagos, then there's little or more government can do. So there's an opportunity for us to look at PPPs, both in the demand and supply, where you have a private-public partnership between government and individuals to pull together to engender an egalitarian system where it's totally equitable and people receive the same level of care no matter your social status. And once that is done, then we then begin to see a supply side that generates some level of business, and people begin to invest in it. I mean, you'll find a lot of business people that will tell you that, you know, there's no need for governments to invest in the supply side. Just promise me that once demand is available, then I will invest in the supply side. I will get money from the private sector and build the primary centers that need to be, that services need to be delivered in. We will invest in equipment that the secondary facilities will use. So again, you know, not repeating what everybody else has said, and also catering to the question that you asked, it's important, right, that first of all, the system is organized. As it is right now, we do not have an organized system. You know, Africa, not just in Nigeria, Africa as a continent has that problem where we've not been able to define a healthcare system that would effectively provide quality healthcare services for our people. Thank you.
All right, so what has been ringing true in what all four distinguished panelists have been saying is that we have a very disjointed healthcare system and we need to work seriously on that. So, I mean, Dr. Okogun, I want your take on that. What other virgin area exists within the healthcare system value chain that you think we can harness?
Yeah, thank you very much. Dr. Okulaja has spoken a lot about the economic side of things, what I'd like to call the quantitative part of the value chain. But I would like to look at the qualitative part of it, which has to do with training and research. I think there's a lot that can be achieved through increased training. I believe that even in the private sector, many of us are very focused on delivering clinical services, you know, little investments in the area of training and also research. As an industry, if we really want to get up from where we are now, you know, and begin to, you know, redefine our path to prosperity in terms of growing the healthcare system in Nigeria, I think it's important for us to look at training, you know, beyond just the specialist clinical training that we do routinely. I think one area where I feel is very core, which has been neglected and still been neglected, is in the areas of management and leadership training. No matter how much resources you pump into healthcare space now, I believe that it still end up in the waste, because we don't have a sizable number of leaders in the system to drive the kind of transformation that healthcare needs to experience for us to become competitive globally again. It's not enough to be very good in, you know, as a specialist doctor, but if you are not a good leader, you are not going to be able to, you know, manage the change, you know, that we all envisage. The same way we talk about management, you know, there's a lot that goes wrong in our healthcare system. Even if you go to the government settings and even some of our private settings, probably everywhere, really. I think one of the biggest challenges we have in healthcare is the wastages. We lose a lot in terms of material and financial investment. The outcomes are very poor, despite all the money that have been pumped in. We may think that the government or even the private sector is not putting enough money to the system, but I believe that even what is being put in, we are not optimizing on it, and that is the cost of the death of leadership, you know, and real system management. I normally would say all the time that healthcare needs help. We don't have too many people coming into. I mean, for many young graduates and many smart guys, I don't think healthcare is an employment destination, unless you're a doctor or you're a pharmacist and you don't have anywhere else to go. Not many accountants, not many, you know, economists or people who can help us in healthcare want to come into healthcare to come and use their talent to evolve healthcare. So in that sense, I think focusing on training, leadership training, being able to create an enabling environment to attract the kind of talent that we need to transform healthcare is part of what I think is significant value, you know, that can contribute to the kind of you know, the endpoints we want to get healthcare to. Again, it's research. You know, irrespective of what happens everywhere in the world, there are peculiar, you know, situations you find in every country. If we don't do our own local research, there's no way we can solve our own local problems. You know, and this may not just be scientific research. I mean, management and all that. We need to look at our situation and find local solutions to our problems. So the entire value chain of healthcare as it is now can be enhanced if we look beyond the regular and begin to probably put more effort into research and training. I will be able to just do a lot more than we're doing now, because with every little resource that you throw into healthcare, the outcome can be optimized. Thank you.
All right, thank you so much. Okay, Dr. Dada, are you there?
Yes.
Okay, thank you so much, sir. So I want to go to you now. FMC Ebutemeta was nationally recognized for curbing corruption and excesses in, of course, in the focus institution. And then, of course, through that, you were able to make available resources to do other things that you needed to do in the organization. How were you able to achieve this feat? How were you able to curb corruption? How were you able to prevent wastage in that organization? And then, of course, secondly, how do you think this kind of learning can be cascaded into other public health facilities in Nigeria?
Well, thank you very much once again for the question. I would want to start this by saying that quite a big chunk of that credit goes to the federal government of Nigeria. And the reason is because they came up with two policy framework that aided what we were able to do. Okay. Now, those policy framework and the TSA system. I hope I'm heard, please.
Yes.
Am I still on? Yes.
Yes, you're on.
Yes, the TSA system that the federal government introduced, and then, of course, the digitization of operations that were encouraged also by the federal government. And so, with these two systems on the table, at the beginning, of course, we had this leakage of revenues because revenues were being collected by individuals who couldn't account for what was being collected. There was not just leakage of revenue, there was leakage of consumables and leakage of drugs and stocks and all of that. And those who manage hospitals would realize that these are very familiar problems. And then, of course, there was fragmentation of the financial and policy processes, okay? So the consequences of this, because if your revenue is leaking, if your drugs are being taken away, the consequences basically was that we're owing huge debts, we're owing pharmaceutical companies, we were owing those who were supplying us consumables, medical consumables, diesel and all the rest of them. And we had lost quite a bit of credibility. So we had to sit down to really look at our system and find a solution. And leveraging on the already existing policy framework by the federal government, we decided on first three basic issues. The first one was the payment system. We knew that we had to take a look at the payment system and change the payment system the way it is, okay? So we said that there wasn't going to be collection of cash, at least by our staff, okay, despite the fact that we're located in Onyibo, where, I mean, Onyibo is downtown Lagos, and the majority of our patients actually are comfortable with cash payments. We said if you want to pay, you have to pay by ATM. You could also pay directly to remitter, to our account in remitter, okay? You could pay, we then set up a patient wallet where you can transfer money directly into, all right? You could also go to our website and pay, okay? But if you chose not to use any of these options, we then brought in remitter agents into our compound who would collect cash from you. But your cash won't go to our staff. We're not going to touch your staff, your money. The remitter collects the cash and transfers through their remitter envelope directly into our accounts. And so all of that eliminated the financial leakages, at least substantially reduced them, all right? So then we looked at our stock also, and then said, look, we needed to bring on an electronic medical record system, okay, such that you're not able to access record except through that electronic medical record system. And you won't be able to access the electronic medical record system unless your payment has been confirmed electronically also, okay? And so we brought in our laboratory. We completely eliminated paper and pencil operations in our hospital, okay, at least as far as the clinical services was concerned. We brought in the clinical services into the electronic medical record. We brought in the laboratory into the electronic medical records. The same thing with the radiology and virtually all of what we're doing. So it was possible for us to track the drugs, okay? I can sit down in my office and track the amount of paracetamol that was supplied to the hospital and the amount of paracetamol that was prescribed by the doctor, which doctor prescribed who, what patients took how many, okay? How many did we start with today? How many are we ending up with today? And then who dispensed those drugs and those consumables and all of that? And then we then brought in again a CCTV, okay? It wasn't hidden. We told the staff, they were aware that the essential aspects of the hospital that had to do with our financial and service operations, that we already had CCTV there and all of that. And so all of this ensured that we were able to substantially eliminate financial transgression, okay? And then we're able to bring in efficiency, okay? And in the expenditure of the income also, we're very transparent about it, all right? And then in no time, the entire staff bought into the process, okay? And we're then able to generate enough funds to, one, first of all, pay off what we're owing, all right? We had a payment mechanism scheme with the suppliers, and then we paid off what we were owing, and then we signed to a payment scheme whereby within a limited, I think 30 to 45 days, if you supply us goods or whatever, you are paid off, okay? And then gradually, we then started using what was left to try and improve the kind of services that we're rendering. Right? So basically, these were the things that we did, and it has helped us substantially, okay? And then we also realized that there were some areas where we didn't have expertise, okay? We wanted to improve the quality of the kind of care that we give to Nigerians. We wanted to be distinct. And so we started scouting around for people who would help us. And we stumbled into the Farm Access Foundation Safe Care. We invited them, we sat down with them, we agreed, they went through our system and had a quality improvement program for us that we started following, and they were guiding us and supporting us. And so here we are. We have been able to, we've not gotten to our destination, but at least we have left Egypt the way they say. And we hope that sooner than later, we would become the first public hospital that would be certified.
Beautiful, beautiful.
Yeah.
Thank you so much. I mean, listening to you now, one other thing that is clear is the role of technology, like Mr. Abajue emphasized, the role of technology that's helped heavily in, cutting off a host of things that were causing problems for you before. Dr. Okulaja, I want your take on that. What are the things that you think the public healthcare system can do to help curb corruption, wastage, and excesses, leakages?
I think the best person to have answered that question was Dr. Dada, because he has been very successful in doing that. And I work for Farm Access Foundation, and one of the things that we've done is we've been able to support Dr. Dada in setting up the frameworks that has enabled him to curb a lot of the inefficiencies that are going on. I wouldn't really want to call it corruption, because when you say corruption, then it means that somebody has already been sentenced even before he's found guilty. But I think that one of the things that we can do is to look at how we can reduce the inefficiencies in government facilities. And I think one of the main ways which government has actually found it very difficult to do is to make the public facilities autonomous. Autonomous in the sense that if the people that are working in those facilities know that the amount of money that is being generated is what will pay for their salaries, then they begin to pay a little more attention to the quality of service that is being delivered. They begin to pay a little more attention to missing items, and also financial misappropriations and all of that. So I think that's one of the first things that needs to happen. I also think that in the management of public facilities, we must have some level of private sector injection. The private sector, although a lot of people know that, think that private sector is just profit driven. Yes, private sector is profit driven. I wouldn't want to look at it as being profit driven, but rather incentive driven. And if wherever you find incentives, you begin to see efficiencies come on board, because then you have KPIs. And when you have KPIs and you're measured against the KPIs, then people begin to sit up. A lot of assumptions, and again, it's to a certain extent really true. The civil servant is guaranteed his salary, based on just his being employed. Performance is not really an indication on whether he gets his salary or not, which is very different from the private sector. And that is why you begin to see the differences in the way the private sector will treat a business and the public sector will, treat an encounter. So I think in addition to what Dr. Dada said, I think it's important that governments begin to look at, setting up some level of autonomy within the public sector hospitals, and also looking at private sector infusion at the level of management and leadership of these facilities. Thank you.
All right, thank you so much. Thank you so much. So just for 2 minutes each, briefly, I want to start with Mr. Abajue. I want your thoughts, randomly, on sustainability and profitability in the healthcare sector. I want to start with Mr. Abajue.
Okay, thank you very much, Shola. I think that whilst the issue of sustainability and profitability is very important and will never become less important, but I think that if we understand where we are as a society, then we need to think very deeply about how we can make it affordable to the population. The vast majority of Nigerians are poor. And in at least in my journey in health insurance and trying to get across to many people, the reality is that we have to make this thing affordable. So the things that can make it affordable are things like scale and the use of technology, so it can reduce the cost of access, but it means changing a couple of things in what we do. So, but affordability, we need to put at the front of our minds, all right, so that people can afford to pay for access to care and not be using corner approaches, for want of a better expression. I think this is really important. From a hospital service provision, we've got to give the hospitals a chance to survive. We have to give them a chance to be able to earn a good return on their investment. And both parts, the demand and the supply, must work together. Thank you very much.
All right, thank you so much. Dr. Austin, Dr. Okogun.
Yeah, I'm here. Thank you. Yes, thank you very much. Talking about sustainability.
Yes, please. I just want you to.
I'm here. Yeah, talking about sustainability, I like to look at what's happening in the private sector.
Yeah.
Yes, particularly as to the fact that not many promoters are able to succeed themselves, in terms of their businesses. I mean, you either have the business die before the promoter died before. So there's no, the decision in the system is not largely a failure. That's it, because many organizations were set up to have either family succession or thereabout. So that has been a major problem. And I think we need to begin to think about that from the beginning, from the onset of setting up our businesses. A lot of guys, because an afterthought for many people, and they struggle with it. And it's really not an easy thing unless you have prepared for it. So I think that there needs to be a rethink in the way, we design our businesses, for sustainability. Talking about profitability, I think it's a whole mix of so many factors. I mean, you have to keep driving revenue up and driving costs down for it to remain profitable. The elements that impact on even revenue generation, elements that impact on cost have to be alive, in your everyday business. The very key indicators, that we signal, danger, to put a risk to profitability. Things that you must keep your eyes on and stay above water. I think that here in our country, what we need to do in order to help us to remain more profitable, and sustainable as a business. Also to understand, the unit economics of what we do. Very often, we make a lot of assumptions in the course of doing our businesses, and the fact that you're making revenue doesn't mean you're being profitable. And the kind of accounting that we also subject our businesses to can sometimes also expose us as profitable or not profitable. So what I'm saying in essence is therefore that all of us who are in the private side, because that's where I play, that's what I know, we need to keep our eyes, on managing costs. We live in a very fluid environment where, inflation, goes up and down, in fact, up more than down, exchange rate exposures and all those many factors that they will push costs up. So we need new ways of thinking around our business in order to, keep costs down or contained. There will be need for more collaboration, among healthcare organizations, particularly for large-scale procurement in order to drive down costs. There need to be, many joint venture businesses among all of us, because like someone mentioned about the fragmentation of the private healthcare system. Usually when people talk about fragmentation, I like to think about it in terms of service fragmentation. But if we build joint venture and collaboration kind of schemes, MOUs, we can do a lot together. These silo activities need to stop. We need to come together to do something large. We need to be brave enough to embrace mergers, to build, institutions that can outlive us. That makes us more sustainable, that makes us more profitable in the long term. Thank you.
All right, thank you so much. Dr. Okulaja.
Yeah, thank you very much.
Someone said something. Your random thoughts on sustainability and profitability.
Yeah, so someone said something to me once, and it was what Winston Churchill said, basically implying that we should try not to waste the crisis. What the COVID pandemic has done is that it has shown that we do not have a resilient system in Nigeria. We were lucky based on a lot of other several factors. And I think that, it's time for us to come together and begin to see how we develop a healthcare system that would involve both public and private sector in each level to build a resilient system. It is also foolhardy to think that the government will do it alone or government will facilitate the purchasing power for people to access healthcare by itself. Government is broke, and as we can see. So a lot of the funding that may be required to provide quality healthcare must come from the private sector. However, the private sector is highly fragmented, it is atomized, and it has poor quality oversight. There's also a need for regulation by government to come, to see how they can provide some level of, mentorship to the private sector, and also create an environment that would facilitate the ease of doing business for these facilities to come on board. A lot of people have talked about India, and you did mention India. One of the things that I don't think anybody mentioned here was that the government actually made affordable financing specifically for healthcare for it to build this ecosystem, and there was a targeted objective of making India a medical tourism hub where people can come from all over the world to access healthcare. So that was driven by policy, and that is what has led India to what it is today. So again, there's a need for each sector to know what it can put on the table in terms of government putting on board policy and regulation, and then the private sector coming in and putting in some level of efficiency and financing, actually. There's an assumption that the informal sector is poor in Nigeria. That is not true. The informal sector is highly rich. And so what we need to do is to see how we can bring together all the resources to help build a sustainable healthcare system that would run on its own and will not at any point in time require some level of government fund injection or intervention. And this can only happen when healthcare is seen as a business and not as a social service. Thank you.
All right, thank you so much. And Dr. Dada,
Well,
finally, your random.
yes, finally, I think that in the public health space, profitability should not be about naira and kobo. As far as I'm concerned, it should be about how many of our compatriots were able to prevent from falling off from the social protective mechanism, and how efficiently we're able to do this. Okay. Like I said earlier on, I think there are two basic things that we need to get right. If we get those two basic things right, at the end of the day, it's going to make healthcare a lot cheaper, and it's going to make it a lot available, and it will create accessibility. The first one is that the system is too fragmented, particularly at the primary healthcare level. You find people who have malaria, they rather go to the tertiary health system because they don't have confidence in the primary healthcare system. The primary healthcare system is under the local government and to some extent the state government. We need to strengthen our primary healthcare system. Okay, we need to create accessibility, and the only way we can do that is if the system is so organized that people would have confidence in it and they would rather approach it, okay, for their basic health needs than go to the teaching hospital. When that is done, then preventive, like we all know, it's always said that prevention is always cheaper, okay, than curative care, okay. So if we're able to prevent a lot of these diseases that ultimately would drain a lot of funds from the healthcare system, if we're able to prevent them at the primary healthcare level system, then it becomes a lot cheaper. The second thing is that we need to bring in finances into the health system, okay. And to my mind, the best way to bring finances into the health system is through the health insurance scheme. Okay, one of the major challenges of the health insurance scheme is because we have a very large informal sector, and the challenge they are facing is how do we bring this informal sector into the health insurance pool. Now, if we have only 5% or thereabouts in the health insurance system, you can imagine if we have about 90-95% of our compatriots, even if it is 60-70% of our compatriots in the health insurance system, you can imagine the amount of resources that will be available. When these resources are available, it can then be deployed to create efficiency and to create better and quality care in our system. It's not that people don't fall sick in Nigeria. The truth is that they are not able to pay for it. And there is nowhere in the world where people are able to pay from out of their pocket for their health care. What most people do is the health insurance scheme. So that people can, so for instance, if you have an MRI, and we have a population of 200 million for God's sake, okay? When people buy and install MRI as a business venture in Nigeria, they'll be lucky to do maybe 10 or 15 in a day. But with health insurance, the man who has installed MRI will probably be able to do 60, 70. That creates efficiency also. And that will bring in the private sector to actually invest, not just in the diagnostic area, but also even in the hospitals. And when you establish the hospital, then you are sure, because of the population that we have, that people will come. People will come because they don't have to pay from their pocket, okay? And that brings the kind of money that we're talking of, the kind of resources we're talking of into the healthcare system. For me, once we're able to solve those two, then the other blocks would come in. The challenge we have presently is because the system is fragmented, like I said, and people, because of that, people don't have confidence in the healthcare system. And a lot of people who are sick rather go to chemists as a first step, and then maybe to their churches and to their mosques and to the traditional homes as a second step, okay? And then they don't come to the hospital until it is very late. When they come to the hospital, the kind of money that you need to take care of them has become very huge. They can't afford it, okay? And those are the major problems. And if we're able to get these two basic things right as a first step, we have a strong health insurance scheme, we have a very well-organized primary health care system, then I think every other thing would follow.
Thank you so much. Thank you so much. So, I mean, at this juncture, I would pick one or two questions from the Q&A section so that we can take that. We have just maybe 10, 15 minutes to round up. Dr. Okogun would need to, I mean, he had some other assignments. So.
Yeah.
facilitate this? So I'll call on Mr. Abajue to take that for me. Did you get that?
No, I didn't get that. Which one?
Okay, so I said the question reads that we are challenged with data in Nigeria. How do we advocate for a better data management system or health record to facilitate improvement in our healthcare system as a whole?
Okay, so I think if we're going to get better health records, we all have to kind of push towards transparency in what we are doing. And I'll come back to the same thing I've said all the time, that better health records actually are an outcome. They're a byproduct of something else that we are doing, all right? So if we think about the process of delivering healthcare, whether it's the demand aggregation process or it is the delivery process through hospitals, the transparency of the process, doing things like what Dr. Dada explained that he did in FMC Butemeta, those things using technology result in data being clearly available as a byproduct. That byproduct allows improved analysis, telling you what to invest in. So to drive that is essentially to improve services through leveraging technology, all right, and you get the data as a byproduct. You can try and mandate it from a policy perspective, but that will be very slow. It'll be hard because ultimately investment is required. But what you really need, I think, most practicably is where the payers of the service are demanding that that service be rendered transparently, and the returns and the information that is required to do it is in the open. That will lead the providers of the service to adopt technology, and therefore the data will be available as a byproduct.
All right. So another question reads, and I want Dr. Dada to start with this because it speaks directly to where it is. It says, residency training is the primary platform for postgraduate development of doctors in clinical practice in Nigeria. In view of the huge need for specialist care, what are the hindrances to task shifting as proposed by the WHO, where some set of activities are given to a lower cadre of providers? It says we have in some nations where there are master's or diplomate courses or other lower cadre of full-scale residency program. How do we go about this? What are the challenges for the National Postgraduate or College or the Medical and Dental Council as it is to creating human resources to fill this gap?
Well,
so I want Dr. Dada to.
Well, I think that's a very beautiful question. You know, one of the challenges in the training of specialists is that it's a training that is thorough, okay? Because at the end of the day, once you say somebody is a specialist, it means that it's an expert in that field, okay? And the buck stops on his table. So if you're going to train him, you need to ensure that it is thorough. And on the average, it takes about 4 to 5, if not 5 to 6 years to actually train a specialist, okay? And so that takes quite some time. It's not what you can just go into the market and bring out, all right? And don't also forget that a large number of our young doctors are actually exiting the country. So it therefore means that the catchment number for those who actually want to train is actually very limited, okay? That is the first point. The second point too is that the number of training centers are very limited. In establishing a training center, you need to take into consideration 3 very vital points. The first one is the trainers. Do you have enough trainers in the training center? The second point, okay, is do you have the critical mass in terms of patients so that there can be a widespread of disease process that the candidate can be trained on? And then, of course, the equipment. So it's not all hospitals that have this capacity. This capacity exists majorly in the tertiary institutions, okay? So these are the factors that have limited the number of specialists that can be trained. And it's not just limited to Nigeria, it's all over the world. Okay, and that is why recently you find out that in the UK, the door was opened so that they can poach from other parts of the world. In the US, the USMLE system has always been there to encourage, because they don't also produce enough. All right. So these are the factors that have limited the number of training slots and training candidates that are available. But in terms of tax shifting, that has been going on here too for quite some time. We have diploma in anesthesia, and they are doing very well on the field. Okay, they are not food specialists, but they have undergone a little more training than the basic MBBS. We also have diploma in a couple of other areas. Okay, but what is not yet done, and which is extremely difficult, is to actually shift some roles that are meant for doctors to to the other players in the health system. Now, one of the major reasons why this is difficult in Nigeria is because the command and control system is extremely very weak. I remember a couple of years back, maybe about 12 years back or thereabouts, when I was about 14 years back, in fact, when I acted as the Secretary General of the Nigerian Medical Association, you find out that majority of the complaints that you get, okay, about mismanagement of cases and all the rest of them, by the time you investigate, of course they will write that the doctor has mismanagement, but by the time you investigate, you find out that it's actually, in a large number of instances, non-medical, non-health workers, okay, who have set up shops somewhere, who have caused all of these problems. So by the time, if you do this shifting, tax shifting as it were, without a strong control system, then you create a situation where just anybody can go in, okay, without control and start treating Nigerians. And I'm sure you know the consequences of that, okay? Health, once taken, cannot be restored, okay? Once somebody is dead, you can't bring him back. And so I believe very strongly that it's an area that we need to go into with a lot of caution. It's an area where we need to put in a lot of control before we can actually start that. And to my mind, that is one of the limiting factors that is actually affecting this concept of tax shifting in our country.
All right, thank you so much. So let me just pick one. Let me look through and pick one or two more questions. So, okay, Dr. Okulaja, I want you to take this. Someone said, what do you think is the most critical step towards achieving universal health coverage in Nigeria? Did you get that?
Thank you very much. Yes, I did. I got that question. So right. Basically, I'll give an example of a country that I quote all the time in achieving universal healthcare coverage. And what they did was they went through 4 critical steps. The first step that, this country is Thailand, by the way. And Thailand, about 10 or 15 years ago, decided that they were ready to move their country to universal healthcare coverage. And the first thing they did was they invested heavily in their primary healthcare system. And so both public and private, they ensured that the primary healthcare system was functional. And once it was now functional, it became an attractive measure for people to get onto a health insurance scheme. So the second step that they did was they set up a mandatory health insurance scheme where everyone was meant to come on board. And then when they did that, after establishing some level of mandatoriness to their health insurance, the third thing that they did was that they made both public and private facilities compete with each other. So basically, they made those facilities autonomous. And so when that happened, it drove up quality and reduced the cost of service of care. And then the last thing, one of the last things that they did was they then moved all their funding to demand side, which basically meant that instead of using their funding to build hospitals and build structures, they use their monies to facilitate the ability for people to access healthcare, and then they increase their the percentage allocation to healthcare. And within 10 years, Thailand was able to achieve some level of universal healthcare coverage. And so basically there are lessons to be learned there, which basically is that one, your primary healthcare, system is very important and serves as like a carrot on a stick for people to get onto a mandatory health insurance scheme. One of the things I noticed recently is that when private HMOs go out to market their packages, one of the things they use is the private facilities they have on their list. They tell you, oh, we have this hospital, we have that hospital. And based on those hospitals that they have on their list, people then get onto their plans and onto their systems. And that's one of the things that we must actually learn in getting a social health insurance scheme in place. So there's a need for government to invest in the primary healthcare system. And when I say invest, it's not just looking at financial. You can invest also in putting in place policy and regulation and find ways of bringing in the private sector to do that. And of course, like everybody else has said, it's important to find a health financing mechanism that suits your environment. And if you notice, I've been very careful. I'm a huge proponent of health insurance, but I've been very careful not to just limit it to health insurance. There are other ways of financing a healthcare system beyond health insurance, and there is no one size fits all. There can also be a mix. So, for example, you go to the northern states. It will be difficult to implement a health insurance scheme a mandatory health insurance scheme in the northern states because the population of people that can actually contribute is very limited. In Lagos is a different situation, right? So it's important that the financing mechanism that is determined to facilitate the ability for people to access healthcare is tailored to that environment to ensure that it actually works and it's not just a one-size-fits-all environment. And it's also important that government begins to understand their role in the healthcare system, and the private sector also begins to understand their role. So if roles are delineated and there's a recognized limit to decentralization of what should be given to the private sector, then we may begin to see some baby steps towards universal health.
All right, thank you so much. So finally, the last question will go to Dr. Okogun. The question here says, why has there been failure of pulling hands together amongst providers? I mean, so one of the things we have discovered in Nigeria is that there are not too many partnerships when it comes to healthcare businesses. Why is there such a case around here, please?
Thank you very much. Well, I'm sure you, on the one hand, talk about pulling hands together among providers, then you talk about partnership. So is that a partnership among individual specialists or among various organizations themselves? So yes. It's all about coming together. But I think it's about buying into a shared vision. That's what it is. I mean, when most organizations have different kinds of vision, and some are driven, by the need to sponsor their lifestyles. Some are driven by the need to establish, institutions that will outlive them. So these, varying drivers can be barriers to collaboration in a sustainable business. So we don't have a lot of mergers. Even I've seen so many failed attempts at mergers, and when you discover that your objectives are different, then it's better to stay apart than to come together. So I think that may be one of the issues. But I think that it's something that we must look at as an industry, because what we're going to continue to have is failed institutions, because unless you inject in new energies into the system, because we know we are going to age, naturally, there's going to be time that you will not have enough energy to drive the business. So in terms of businesses being able to attract new partners into their system, it need to be deliberate, actually. You need to deliberately want to partner with colleagues, whether because they've got other skills that you don't have. Because no one man has every skill. Healthcare is such a business that, or such an industry that there's no single specialty or single individual that can do all. So at the end of the day, you need to collaborate, to be able to deliver the kind of, broad-based specialty services you want to offer. So there'll be need for, rather than think about the fear that, the partnership could break down, it's rather to think more positively about what will make it succeed. And when you put your energy in thinking about the positive, you end up succeeding in doing that. So I would also want to say is the inability to harness your vision, to bring your objective, to be the same, that be one of the main factors why people are not able to stay together. But on the other side of when it comes to organizations working together, I also get amazed how we tend to focus more on competition and collaboration. We're in an industry where there's so much demand for the services, and we are not thinking about opening up the market, trying to say how we can drive more numbers our way. Everybody fights for that little 5% that's active in the market. But like I said before, we need to rethink the industry. We need to rethink our businesses. We need to have a common, vision, that will help us to take advantage of the enormous resources, that are buried in this market. Yeah.
All right. Thank you so much, distinguished panelists. Thank you, Dr. Olamide Okulaja. Thank you, Mr. Obainnia Abajue. Thank you, Dr. Adedamola Dada. Thank you, Dr. Austin Okogun. And of course, to all our participants, I say a big thank you. A lot of things has been said. I mean, we have spoken about restructuring our health care sector. We have spoken about technology, the input of technology. We have spoken about data. We have spoken about scalable healthcare system. We have spoken about, revamping our payment system. And then, of course, we have spoken about harnessing the fragmented system and ensuring that roles are clearly defined. Now, each and every one of these things that has been said requires strong leadership and then, of course, a good support and goodwill from the government side to ensure that those policies are first created and then, of course, implementation, because it won't just be by mouth alone. So, like we say, health is wealth. It should also mean that, of course, the health of the citizens will bring, wealth. But of course, health business itself should bring wealth in the real sense of it. I mean, I'm always amazed at the budget that is available to the NHS in the UK. When I checked it, it's kind of larger than our national budget, the budget that is available to the NHS alone. So that being said, we will go back home and then go back to the drawing board and ensure that all these things that we have spoken about, we will implement them in our private lives. Of course, for people like myself who run a private healthcare system, of course, I will need to go back to the drawing board and then rejig a lot of things. And then, of course, for people who are listening, who are in the public healthcare sector, Dr. Dada has said and are thrown up a whole lot of things. For those who registered for this conference, I'm sure we'll look at ways of ensuring that the recordings are made available and then sent across to you. But of course, because it's a private material, it will need to go through certain processes before you get it. So we don't want you to fret about that as much. Once again, I wish everyone a happy independence. Thank you so much for coming. God bless you. Thank you. We have come to the end of the meeting. Thank you so much.
Thank you
Thank you very much. Thank you.
Thank you very much.
All right. Okay, bye.
All right.
Thank you.
Bye-bye.
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 Yeah.